How much should you be paying your associate doctor? Well, that depends on a number of factors, and that's what I want to talk about in this week's tip. So this week's tip is a lot longer. It clocks in at close to a half hour than most of our tips. I filmed it not that long ago, and the idea was we didn't know exactly how we wanted to use it, because initially, we try to keep our weekly tips in the 7 to 10 minute range, unless I'm going, in which case they're usually too long. But then we thought, we're getting a lot of questions about associate pay plans and how to structure them, so we thought, what, heck with it, we're just going to do it as a weekly tip. So, without further ado, I'm introducing myself from myself, which is awkward. Here you go. How much should you pay an associate? So, how much should you pay your associate? Well, whether you have one now, or you're thinking of getting one, or if you think an associate is in the cards in the future, this is definitely something that you're going to want to figure out. And obviously, associate pay, when you're adding an associate dentist, is only a part of the equation. When you're hiring an associate, there's a ton of things to consider. Obviously, pay is the biggest one, but there are other things like clinical excellence, speed, philosophy, that associate's long-term career plans, and of course, whether you actually need an associate. That being said, that's a lot of information, and this would become a 3-hour show if I were to do that. So for this week, we're going to focus on the number one issue, which is how much do you pay, or how do you pay an associate? Now, how you pay an associate has a lot to do with how you are going to utilize that associate. And while there are a lot of different models that people set their practices up with their associate doctors, I'm going to focus on the top three, the three most common models that you see in dentistry. And those three models are the traditional model, the production doctor model, and the autonomous operation model. And what I'm going to do is I'm going to explain each. And as I explain it, I'm going to get into a little bit about what each is and how it's structured, as well as what's the maximum percentage that you want to pay this doctor in order to make sure that your practice stays profitable and viable. Now, how you pay them, as far as, this is base salary, this is percentage, etc., is really not that critical when I'm talking about percentages. When I'm saying a percentage, I'm saying no matter how their pay is constructed, you don't want to exceed this much. That's basically when I say a percentage, it's not like you have to pay them on a percentage. It's just that whatever combination of payment methods you use don't exceed this percentage. And I'm also going to talk about how you structure associate pay towards the end of this episode, because there's a few things to consider there as well. So let's jump in with our first model, which is the traditional doctor model. So what's the traditional doctor model? This is the associate model that we've all become used to over the last umpteen years, 30 plus years. This is an established doctor who hires another doctor into the practice. It might be someone who's just out of school. It might be a more experienced doctor. That doctor just out of school might be looking for a mentor. But basically, you're hiring somebody to do the work that either you want to free up from your schedule or that you don't want to do. It might be emergencies, kids. It might be some endo. This doctor might be on call during the weekends. Basically, you're trying to free up your schedule so that you can focus on more time off or more productive procedures. This doctor may or may not be expected to bring new patients into the practice. This doctor may or may not see some recall patients, okay? But generally, you're going to have them, when they see a patient, if they diagnose treatment, you're going to expect them more or less to be able to present that treatment and put it onto their schedule. They're sort of operating within your practice. They're part of your practice, but it's not like you're filling their schedule necessarily. That's the traditional model. Now, how are you going to pay somebody on the traditional model? As far as the traditional pay plan has been, usually it's 30% of production or 30 to 35% of collections, and usually the lab bill is split. Now, personally, I'm a bigger fan of the collections aspect of that, only because generally it's you're paying them with actually money you did receive as opposed to production. There's always a chance with production, if you don't have it well set up with financial arrangements, that you don't get paid, in which case you're paying for treatment that you actually haven't been paid for. But that's essentially how that shakes out. That's the percentage that you want to set up in this traditional associate model. So let's talk about model 2, the production doctor model. Now, the production doctor model is a bit of a newer thing on the scene. As a matter of fact, we started seeing it with our clients. We started working with clients to set it up back in the mid-2000s. I saw it really begin to take off in like 2005. Basically what the production model is, you as the owner doctor diagnose and present all of the treatment in the practice. You're presenting everything. You're seeing every patient that needs treatment. You're diagnosing it, presenting it, and getting it accepted. And then that treatment ends up on your associate doctor's schedule. All right, so essentially all treatment is flowing through the owner doctor. Now, for that to work, there's a few things that you have to have in place. One, you have to have adequate volume. If you try to do this, if you're a sole practitioner and you've got one 4-day-a-week hygienist, you probably don't have enough, it may be 20 or 30 new patients a month. You don't have enough volume coming in the practice for you to be able to do this and keep yourself busy seeing and diagnosing treatment and keep production doctors busy. That doesn't work. So usually what you're looking for is you at least want 2 full-time hygienists and maybe 50 new patients a month. That's usually enough volume to keep a production doctor busy. Or you maybe more new patients and less hygiene. I like to see a little bit more of both. The other thing that you need in this model is you need a very skilled clinician. You need somebody who can do all the work, all the procedures. Now, obviously, that you could say that's the case with every associate. As a matter of fact, we don't really see this with our clients, but I have seen situations where I've been speaking to a dentist. Actually had this happen to me twice in my career where a dentist said they would never let their associate work on them. I was not happy about that. Why would you let somebody or inflict somebody on your patients that you wouldn't let touch you? So obviously you want somebody who's got good skills, but in this case you're looking for somebody who's been around for a little bit and can work competently, efficiently. They're used to working in an efficient, tight scheduled environment, not somebody who's just out of school who maybe is a little bit slower. I mean, look, there's always outliers with somebody who's just graduated, but you're looking for somebody who's got some experience. That's the other thing you need for this model to work. The third thing that you need is you need a well-structured organization, all right? So let's say you're seeing, 8 new patients a day and you've got 2 to 3 full-time hygienists going with recall. So you're bouncing between recall appointments, new patient exams, and treatment presentations. You might have 1 or 2 treatment coordinators that you're working with. Well, that's a lot of volume. So in that situation, you're going to want to make sure you have a well-structured organization, which, again, this is something you could say for any dentist that wants to grow. You want a competent, trained office manager. You want well-trained treatment coordinators. And you need a good organizational structure that you guys are all working under to make this work. Now, one thing I want to point out with this production doctor model, and again, just for some terminology, we call the associate or associates that you have actually doing the treatment the production doctor. And you as the owner doctor, if you're presenting all the treatment, you're the sales doctor, all right? So just so we've got the terminology down. So if you had to sell a case or present a case and close it, get the patient to accept. Let's say this case was, 2 implants, 6 crowns, and 4 root canals. How long would it take for you to present that case and get the patient to accept? Maybe 20 to 40 minutes, depending on the patient, of course. Maybe an hour if the patient has a lot of questions. How long would it take for you to actually do and deliver, not just prep, but do all of that treatment? Hours and hours and hours. So what this tells you, assuming the volume is adequate, is one sales doctor can technically keep 2 to 3 production doctors busy. There's enough volume because the amount of time it takes to close it, sell it, so to speak, and then actually do it, there's a huge disparity. The other thing is, because if you're doing this, you're not the one actually, as the owner doctor, doing the treatment, the percentage of compensation to a production doctor is going to be lower than in a traditional model. And for the production doctor, it's actually a bit of a dream job when you think about it. You're an associate, you get to come to work, put your gloves on, go in the operatory, and do, your morning is 6 veneers and 4 crown preps. That's a nice job. It's actually pretty cool. So this brings us to, what do you pay a production doctor? Well, you'll be covering all the lab fees. I'll say that up front. But you're going to pay a production doctor between 20 and 25%. Now, I should sort of fill in a little bit of the blanks here, because again, I was very focused with the traditional model, 30% of production, 30 to 35% of collections. Generally, the production doctor, you're paying them on production. in a lot of cases, if you have this whole model that I've described, where you're presenting the treatment, you have treatment coordinators, et cetera, your financial arrangements are going to be pretty tight. In a lot of cases, patients may even be prepaying for their treatment, or they've done some type of patient financing to pay for their treatment. That said, if you were to set something like this up, I would consider, let's say, for example, there's patient financing involved. Let's say it's a $10,000 case, and you're writing off 10% of that due to the patient financing. So, $10,000 was the value of the treatment. The office is actually receiving $9,000. I would pay them for the percentage of what you actually received in the office, that $9,000. I would not pay them on the $10,000 with that 20 to 25% range. Now, when I say 20 to 25%, you might have rewound the video a little bit, like who's going to work for 20 to 25%? And I've seen this happen with clients when they're interviewing an associate, and they get to that point, well, what does the job pay? 20 to 25%. The associate, of course, is going to balk because they just had an interview yesterday at another practice, maybe a corporate practice or somewhere else, where they were offering them 30%. Well, the job that they just interviewed for was a traditional model, where they're going to get to do all the work that the owner doctor doesn't want to do, or they're going to be on some other type of compensation plan in a corporate office. So what are they going to produce? $30,000, $40,000 a month maybe? With a production doctor, if you've got a productive practice, I would be looking for that production doctor to be doing 60, 80, 100 a month. If they're doing 30 to 35,000 a month, that's a disaster, because you're selling a heck of a lot more treatment than that. So generally, if you're interviewing a doctor for that production doctor position, they may balk at first, and I'd expect them to. But then what I would do is actually just show them the numbers. They might go, well, I was going to get 150 at this office. You go, okay, cool. Well, I expect you to produce 80,000 a month at this office, and I'm going to pay you 22%, in which case they're going to earn, $17,600. Yeah. Or over $200,000 a year. And not only that, they're doing all the cool work that they love to do. And again, remember, this is a doctor who is an experienced clinician, all right? They're used to operating in a fast-paced environment. They can take over for you clinically. That's critical. And one thing I should also mention, too, during the transition phase, when you're moving from, where you're the sole practitioner to maybe adding a production doctor associate, and you might even keep this way after the transition, you may still do some clinical. Let's say, for example, the associate that you've hired can't place implants, and you like placing implants, or you just want to keep placing implants on your schedule. Well, you might have a couple mornings a week where you place implants, and the rest of the week you present or you diagnose and present treatment plans. There's different ways of setting this up, and usually when an MGE client begins on this journey, obviously we make sure they're ready for it first, and then we sort of help them structure it so that it works out best for them. Last few words on this is, number one, in all models, when you start adding an associate, there's something I want you to consider, which is you're going to reduce your profit as a percentage, but you're expecting your profit as an amount to go up. Essentially, you're getting a smaller piece of a bigger pie. Let's say, for example, you're a sole practitioner doing $90,000 a month in collections, and you're running a 55% overhead. All right, if we look at those numbers, that means your profit is 45%, or about $36,000 a month, a little over $430,000 a year. That's pretty good. Now, let's say you're moving into a model where you're bringing in associates, for example, this production doctor model, and you get the office up to doing $400,000 a month. That's great. Well, your profit as a percentage may go down to 25%. All right, but 25% of $400,000 is $100,000 a month, or $1.2 million a year. There's another advantage with this too. You're the one who's presenting and you're getting this treatment on your production doctor's schedules. What if you want to take 3 weeks off? You want to go somewhere for 3 weeks. Well, chances are one of your production doctors is halfway decent at presenting treatment, or you can train them to do that. That's one of the things we do with our clients. Well, you can have them fill in for you for a couple weeks, and you can take off because you've made sure they're all competent clinicians. And again, you've got a killer office manager who's running the practice, who's going to make sure things continue to roll. It gives you a lot more freedom than if it's just you by yourself. So now we get to our last model, We call it the autonomous operation model. This might be where you have a second location or a third or fourth location, and you have an associate working in this location full-time. So this associate, for all intents and purposes, is you. They are seeing patients, they're diagnosing patients, they're doing recall exams, they're presenting treatment plans, etc. They are the doctor for that practice. Now, when you're setting up a compensation plan for a doctor in this setup, it takes a little bit more work. Number one, because overhead control is always important, especially in the post-COVID era. You really want to manage your expenses. When you're not there day to day, you're going to have even a little bit more oversight. There's also a ton of variables in second locations. How much did you pay for the practice? Did you have to update equipment? What are the costs in the practice? How many staff does the practice have? How large is the practice, et cetera? There's a ton of variables, so I can't just come out and go, give them X percentage, because it may not work. The last thing you want to be doing is paying a percentage and losing money, having to subsidize this practice, practice number 2 from your main office every month. That's just pointless. So you don't just do it that way. Before you actually set up the compensation plan for an associate in the situation, and I would do this even before I bought the practice, is the first thing you want to do is take a look at what you would estimate. This is step 1. Estimate conservatively what the revenues for this practice are going to be every month after you purchase it. And I say this because right now, in the post-COVID era, there's a lot more inventory, practices for sale, practices that you can acquire. So before you buy this thing, take a look at, number 1, what can you estimate it will conservatively generate every month? Don't be hopeful here. We're conservative. The next thing you want to take a look at is, what are the costs going to be? So you should have some type of a P&L, and you can determine what costs you're going to carry, et cetera, as you take over the office. And you also want to factor in the debt associated with the office if you're taking loans to buy it. From there, you can take a look at, how much are you conservatively going to generate, what's it going to cost to run it. You'll get an idea of what can you afford to pay an associate doctor in this office. So the one thing you want to do with all of this is be real, because this is the model where I see, most dentists get into trouble, and they end up subsidizing the office. It becomes a big headache and a raging cash burn. And when you figure out, okay, I can afford to pay my associate here X amount, it should include, even with all the debt, regardless of how you set it up. Let's say you paid $500,000 for the office, $150,000 to update the equipment, whatever you paid. While servicing that debt and paying your associate, there should at least be some profit. Doesn't have to be a lot if there's a ton of debt, but it has to be something. Because once the debt is gone, there'll be more profit for you. But you don't want to have it where you're losing money. So let's say you do the 3 steps that I just went over, estimated revenues, costs, et cetera, and what you can pay. You figure you can pay an associate $500. You estimate the office is conservatively going to do about $40,000 a month. And that will allow you to pay an associate $500 a day for 16 days a month. The office is going to be open 16 days. You're going to give them a per diem of $500 a day or $8,000 a month. All right, well then how would you do the pay plan? You might go, all right, it's $500 a day or $8,000 a month, and you give them a percentage of everything over $40,000 because that's your conservative estimate. What percentage do you give them? That's up to you. You could lean on the traditional model and say 30% of collections, of everything over 40. So, if the office does, 60, that's 20% over, they get an extra $6,000, or 20,000 over rather, they get an extra $6,000. However you want to set it up, but then at least the office has met its, baseline, it's paying its bills, and then the associate can share in the profitability as the office makes more money. Now, sure, the percentages are not as great, but, that doctor has a little bit more autonomy. They could do all the work. It's kind of their office. There may be equity in their future in this practice, so it's not a bad deal. And there's a lot of upside. If they get the place doing more and more productive, they have the opportunity to have a better paycheck. And that leaves me with a couple last points I want to mention about this. The first thing is, if you're going to stay, let's say, in Office 1 and you've bought Office 2 and you really don't have an intention in going into Office 2 except maybe to place implants or something like that, or do ortho or something, you might want to think about down the line having somebody there that you could eventually partner up with, even if they're a junior partner. Because here's what you don't want with Location 2, and believe me, I've seen this plenty in my career. You have location 1, it's cooking along, you're making a good living. You buy location 2, you put an associate in there, it starts doing okay. Then the associate comes to you and gives you their notice. You scramble trying to find the right associate, you're scrambling the schedule around, you can't find the right person, or you find limited coverage. So what do you end up with? Instead of working 4 days in Office 1 and having Office 2 running 4 days a week and doing well, you're now working 6 days a week, 3 in each office to keep them both afloat, and each has gone down in production. You sort of avert that problem if you have a partner in Office 2. Now, obviously, if they're going to be your partner, you want to make sure it's the person that you're going to be able to work with. And again, they don't have to be a 50-50 partner. They could buy in at 20%. And then you guys can partner up and buy a third office. There's lots of different ways you can do it. But that's something you definitely want to think about this in the long run. Now, I want to talk about next, just to end off this episode, I want to get into specifically structuring associate compensation, regardless of your model, how you're going to put this thing together. Because you will have associates come in and ask for a guaranteed base of some kind, and how you structure the percentages has a lot to do with what you're guaranteeing. So let's take a look at that. So as we're structuring this stuff, again, to sum up, with our traditional model, we're not exceeding 30% of production, and this is adjusted production. All right, so if you're on a plan and you're getting $600 for that crown and your crown fee's $1,400, you're paying them for the $600. Very important. Production doc model, you're not exceeding 20 to 25% of whatever they generate. And for the autonomous model, you have to work out what the practice can bear, but I would not compensate them more than 30% of overall collections. Now, I would take this a step further, as I just mentioned a minute ago, based upon how much you are guaranteeing. So here's my basic philosophy on this. There's risk for both of you in this associate, owner relationship. You're taking a risk by paying this other professional to come into your practice. They're not as inexpensive as a dental assistant or a front desk person. It's going to cost you a considerable amount of money. The more they want, the more risk is transferred to you. As far as guaranteed. The more guaranteed money they want, the more risk you are taking. The less guaranteed money they want, the less risk you are taking, and the more risk they are taking. You're sharing the risk. So I'm going to give you 2 scenarios and give you an idea of how I would work this out. So let's say we have a doctor. In this production doctor scenario, they're going to work for you 15 days a month. They request a modest base salary, and you've agreed to pay them 22% of what they adjusted production or collections, however you work it out. You're going to get paid for whatever it is they're doing. So let's look at the math on this for a second. So this doctor's working 15 days a month. They ask for a modest base pay of $420 a day, or $75,600 a year, or $6,300 a month. It's what it shakes out to. Obviously, they agree this is their base, and they're at a 22% compensation rate, so they would get their base, and you would take, in other words, what they produce, 22%, and you would subtract their base for it and give them the balance. So let's do some numbers here. Let's say they do $68,000 in a month, 22% of which is $14,960. You gave them that base for their 15 days of $6,300. You then owe them the difference of $8,660. Now, before you agreed to this pay plan, you did some math, and you worked out what we call your associates or your prospective associates' viability point. Your associate's viability point is the amount this person has to generate so that the practice is not losing money. If they generate under it, you're losing money and you're overpaying. If they're generating over it, it's working out well. So how do you determine your associate's viability point? Well, it's actually very simple. So using the scenario we just went over, we have to figure out what this doctor's viability point is. So how do we figure it out? We've agreed to guarantee this doctor $6,300. So we have to determine what $6,300 is 22% of, because that's what we've told this doctor that we're going to give them as a percentage. So we do the math. How do we figure this out? We take $6,300, we divide it by 22, and we multiply it by 100. And what do we come up with? $28,636.36. What does this tell us? It tells us that as long as this doctor's efforts result in at least $28,636.37 each month, you are not losing money. You could even structure their pay plan like this. They're going to have a $6,300 a month base and 22% of anything collected over $28,650 I rounded up a little bit. So you're comfortable with this because you're guaranteeing X amount. This is going to be a production doctor. So if they produce $28,000 in a month and it's not because they missed half the month, it's a disaster. They should be doing a heck of a lot more than that. So this is a kind of, I don't want to say no risk, but it's not a high risk situation. You're comfortable, they're comfortable, they have a lot of upside and a lot of incentive, and it's not putting you to where you're unable to sleep at night because you're guaranteeing them a huge base salary. Which brings me to the next example. Let's call this scenario 2. You have an associate who comes in and asks for a large guaranteed base. Same scenario, production doctor, 22%. But they want a large guaranteed base. They want a guaranteed $150,000 a year, which is $12,500 a month. So now, if we do the numbers on this and we work out this associate's viability point, how would that look? Well, $12,500 a month is 22% of $56,818.18. That's what their guaranteed pay of $12,500 a month is 22% of. So almost $57,000. So let's take a look at this here. Now look, I'm game for things. I'm into playing a game, and of course we can all be hopeful about it. But in our two different scenarios, it's the same job. We're going to do 22% for either of these associates. In scenario 1, this doctor had to do about $28,000 a month, a little bit over $28,000 to reach their viability point. That's pretty low risk. In scenario 2, this doctor has to do $57,000 a month, roughly, over that, in other words, to hit their viability point. There's a higher risk of them not doing that much, 57 versus 28. Do you see? So what do we do in that case? Because now we've taken some of that risk from them and transferred it to us. I mean, you could just paint a picture. Let's say this person did $40,000 in a month and you're guaranteeing them $12,500. Well, you're paying them almost 31% in a production doctor setup. That's rough because that starts to cut very heavily into your profit. So the more, here's my thought on this, in other words, the more you have to guarantee and the more risk you have to take on, you need to adjust their pay plan so they have a little bit less upside than the individual, the guy or girl who's willing to take less as a base. They get a little bit more upside. So what might you do? You might lower their percentage to 20% if you're going to guarantee $12,500. Or what you might do, we establish their viability point at about $57,000. You're going to get your $12,500 and 22% of everything over $70,000. A little bit less risk for you in that case. It costs them potential, earnings at the high end because they are not willing to take as much risk as the doctor or associate doctor was in scenario 1. And I do recommend in any associate type situation, because you'll kind of take a look at what you have going, and one of these models might fit your situation, unless it's a specialist you're bringing in, an oral surgeon or an endodontist, they're going to get paid completely different. But you're going to fit one of these models. Using these percentages, you could figure out, is your associate meeting or not meeting their viability point? For example, let's say you have a traditional model. Let's say you've decided you don't want to exceed 30% of your collections as far as compensation for your associate in this traditional model. Well, let's say you've guaranteed them a base pay of $8,000 a month. All right, well, doing the math, you'd have to take a look at what is $8,000 30% of? Well, it's 30% of $26,667. So what does that tell you? Regardless of how you're structuring the $8,000 you're giving them, it's part base, part percentage, whatever. As long as they produce, if you're paying them $8,000 over that 28,667 number, that works. They've hit their viability point. If they're producing 20, or if you find yourself where they're working and you're sitting reading a magazine in your office or browsing the internet, something's just really not working and has to be done about it. All right, so that pretty much wraps up the subject of pay. I'd leave you with the last couple things here. And that is, when you hire an associate, definitely make sure you have some type of an associate agreement in place. Work with a good attorney on this. And the more things that you can put in writing that you can agree on or figure out, the better. Because I've seen so many cases where, an associate comes in, they talk to the owner doctor, they're thinking a partnership is in the cards. They haven't really set benchmarks as to when that's supposed to trigger or what the purchase price is even. Is the associate paying for their sweat equity or not paying for their sweat equity? These are things you want to take a look at ahead of time, because those are the types of things that cause what could have been a good working relationship to not work. So make sure you get a good attorney to work with on those things. I would do the same thing when it comes to structuring your associate's pay plan. Make sure you have a good employment attorney or your accountant to make sure that however you're paying them works from a taxation and employment law perspective. Anyway, that's about it. I know it was a lot of numbers and a lot of information. I hope this helps you. If you have any questions or you want to find out more about this, you can email me at jeffb@mgeonline.com. And obviously, as I mentioned earlier, all of these things I talked to you about and more are covered on the MGE Power Program, including how to get your practice up to the level where you actually need an associate. And if you'd like to find out more about the MGE Power Program, please contact us here at MGE at 800-640-1140, or you can find us online at mgeonline.com. We'll see you at the next episode, and do well.